Continuing on with our medical problems, we're going to move on to the next system that can pose some real problems, and that is your respiratory system. We're going to talk about breathing problems. We're going to really focus on the main one that you will encounter as you're out there enjoying the outdoors, and that's asthma. Asthma is a very, very common condition for people to have. There are lots of things that can trigger somebody's asthma attack. It can be environmental, it can be exercise, it can be behavioral or psychological, but for whatever reason, asthma attacks cause breathing difficulty. So let's review how and why we breathe again, because it's really important to understanding the treatment of breathing problems. Remember, we breathe based on the pH level in our blood. When that pH level changes, we get more acidic, we get more basic, we breathe faster, we breathe slower, because as we breathe out, we're breathing out carbon dioxide. Carbon dioxide is a weak acid, and therefore we're able to regulate our pH. How we breathe is based on pressure. When my chest gets bigger, the pressure inside gets lower. When my chest gets smaller, the pressure inside gets higher. If you look at this diagram here, you're going to see the ribs. In between are the intercostal muscles, and down here is your diaphragm. As the diaphragm contracts down and the ribs pull apart, those intercostal muscles pulling them apart, your chest gets bigger, the pressure inside gets lower, air is drawn in. Now, moving air in and out of your lungs is more a factor of how much air you can move out than actually the amount of air coming in. Because the more I can empty my lungs, the more air is able to enter back in again. So when I breathe out, my diaphragm relaxes up, the intercostal muscles contract back in, squeezing my chest and pushing the air out. The more air I'm able to push out, the more air I'm able to breathe in. With that in mind, what's going on with asthma? Well, asthma is an air trapping problem. It's known as a reactive airway disease, meaning it's reacting to something that you're experiencing. Again, could be the environment, could be stress or exercise, but it's reacting to that. In fact, it's overreacting. And it overreacts by clamping down on the airway passages and increasing mucus production inside your lungs. Now, in a normal reaction, this is fine. If you don't have asthma, you may react this way. Now, if you think about it, why would increasing mucus production and clamping down on the airways be a good response to a foreign contaminant? Well, if I clamp down the airway passages and I increase mucus, I keep a lot of that foreign contaminant out. But the problem in asthma is it's an overreaction. They continue to clamp down and continue to produce that mucus. And what happens there is every breath they take in, air gets trapped inside their lungs. When they breathe out, they can't fully empty their lungs, which means the next breath they take in is a little bit less, and they trap more air. They breathe out, they don't fully empty, less air in, more trapping, and it continues in that cycle. So what does asthma look like? Well, the nice thing is, asthma will be the easiest diagnosis you will ever make with Wilderness First Aid. You're going to come up to a patient, and they're going to be doing something like this, or like this. Now, this is a classic position, and I want you to remember it. It's called tripoding. They're sitting there, and they're struggling to breathe. And you're going to say, "Sir, ma'am, what's going on? What's the matter?" And they're going to say, "I'm having an asthma attack." Congratulations, diagnosis made. All right? And you might say, what about the person who's having difficulty breathing and doesn't know they have asthma? It comes up. However, you can't have an asthma attack without having asthma. So if someone is having difficulty breathing and they don't have asthma, then it's not asthma. It's something else. And you have to ask the questions, do the detective work to try to figure out what it is. But they're sitting like this, they're hunched over, they're resting, they're tripoding, and they're trying to catch their breath, and they say they have asthma. It's asthma. So what are we going to do for this? Well, just like other medical conditions, the first thing is try to calm them down. The more I can calm them down, the slower they can breathe, the more they can breathe out. A couple of other things before we get into medicines you can try to have them do what's called pursed lip breathing. Pursed lip breathing just means you're breathing like you're blowing out a candle. This is a technique we actually use in a lot of other areas, but specifically in mountaineering, you'll find yourself at high altitude doing this. What this does is it increases the back pressure in your lungs. When I breathe out through pursed lips, I have a higher pressure in my lungs. By doing that, it's helping to try to force some of that air back out. These may work, they might not. What does this patient ultimately need, if they have it, is their inhaler. Now, do not get hung up on the packaging again, all right? This is a rescue inhaler, but you don't want to just look at the packaging. You want to look at the medication. You're looking for their rescue inhaler, and the medication there should be something like albuterol or another one called ipratropium bromide. But if you see albuterol, even if it's albuterol with ipratropium, that's perfectly fine. If it doesn't say those drugs or one of those drugs, it's not a rescue inhaler. It might be their daily inhaler that they use, but that is not going to help them in this situation. You want that drug. Now, why is it important, especially when it comes to asthma? Well, forever and ever, rescue inhalers were really the only thing that came like this, in this little shape with a cap and this little tab right here. And in fact, it came looking like this, even red with white. Up until a few years ago, there's a medication that's on the market right now. It looks exactly like this. Not just the shape, but it's actually red with a white cap with this type of bottle. But it's not meant for asthma. In fact, if you give that medication by mistake to an asthmatic, it will kill them. Read the label, albuterol or ipratropium, or both together. Now, what does an inhaler do? What is this fast-acting inhaler going to do? Well, what this does is it opens the airway passages. That's what it's meant to do. It takes all the airway passages that are in here and it fully expands them. Why is that a good thing? Well, now they can move more air back and forth. You're going to help them with this. This will be their prescription. You're going to help them with it. They should know how to do it, but I'll explain it. They're going to take the top off. This part goes in their mouth. They then have to coordinate. They're going to put it in their mouth, breathe in, and squeeze down at the same time. It comes out as a mist. That goes into their lungs. Now, how many times can they use this? What's the dose? The answer is until the asthma attack is gone. They can use this as many times as they need to until the asthma attack is gone. There are some side effects to this. One of the side effects is it makes people a little nervous, a little jittery. They might get a headache. They feel kind of amped up. That's fine. That's normal. Don't worry about it. But they can use this until it's gone. And hopefully this relieves the problem, relieves the pressure that's inside their lungs, allows them to get that air out. If that doesn't work, or in conjunction, there is one other technique that you can try. It's not the best thing, but if all else fails, you can give it a whirl. It's called a bear hug. Basically what it is you're going to stand behind this patient. They're struggling to breathe. Maybe they took their inhaler, but they're still working really hard. Wrap your arms around them, around their chest. When they breathe out, you're going to squeeze on their chest. What you're doing is you're forcing more air out. You're helping them try to contract that chest even more. It's another option that you have. Hopefully, though, the asthma relieves itself and they are able to move forward. Now, that's asthma. Now we need to talk about hyperventilation. Hyperventilation is also a very, very common problem that you may find. Hyperventilation can be caused by all sorts of things. Usually, though, hyperventilation is a psychologically induced problem. It doesn't mean that it's only a psychological problem. It can be caused by a broken bone, or by a traumatic incident, or by a stress thing, and therefore then the patient starts to hyperventilate. Now, hyperventilation in and of itself is not dangerous. What it is a self-perpetuating mechanism. When a patient starts to hyperventilate, what they're doing is breathing really, really, really rapidly. They're blowing off a lot of carbon dioxide. What that means is their pH is becoming much more basic. As their pH becomes more basic, it starts to affect the way your nerves transmit things. If you've ever had a panic attack or you've ever hyperventilated from something, you know what this is like. What will happen is you're going to start to feel your face tingle a little bit. The patient feels their hands tingling. Their skin kind of feels like pins and needles. That's part of hyperventilation. That's because your pH is out of whack. The problem is that the general public doesn't know that, and therefore they experience those, and what happens? They panic even more, and they hyperventilate even more. As it progresses, you start to get what's called carpal pedal spasms, hand and feet. What goes on is now, because those nerves are no longer functioning correctly, the muscles start to contract, and you get what I call Tyrannosaurus Rex hands, meaning they go like this. Well, the patient, who doesn't know what's going on, looks down and sees their hands like this and they can't open them. What's going to happen? They're going to panic even more. So what's the treatment for hyperventilation? You got to get them out of that cycle. You got to break that cycle. Get them to focus on something else, calm their breathing down, get them to breathe in through their nose and out through their mouth, not because there's some magic scientific principle there, but just because it's really hard to breathe fast in through your nose and out through your mouth. The one thing that people always ask is, what about breathing into a paper bag? Can't we do that? Well, I don't want to ruin anyone's day, but it doesn't actually do anything. Scientifically, it doesn't do anything. Psychologically, it does a lot. Why does breathing into a paper bag work for people? Because they've been told it works. So if that works for somebody, wonderful. Unfortunately, it's not going to work for you anymore because I just ruined it. But that's okay. Lastly, we need to talk about this tripod position again, because that tripod position is really important in terms of assisting a patient in breathing. When a patient is having any type of difficulty breathing, we want them to be in the position that is most comfortable for them and that's most conducive for them to take big, deep breaths, to lower their work of breathing. I want you to picture something. Imagine you just went on a long hike, or you went for a run, or you just did a big workout. You're finished and you're trying to catch your breath. What do you do intuitively? What happens automatically? You just ran a race and you crossed the finish line. The first thing we all do to catch our breath is this. We tripod. Now, we don't call it tripoding. We just bend over and catch our breath. Now, not to be too harsh on high school coaches, but I want to back up and think about all the high school coaches I had, or all the coaches you may have had. You were working out, you were doing your sport, or whatever it happened to be, and you finished the activity, and you bent over, trying to catch your breath. And what were you told to do? Put your arms above your head. Get your arms up. Put your arms above your head. Try to catch your breath. That's the best way. Except, what did you know was going on? You put your arms up, you're like, oh, I can't do it. And you get down and you get yelled at and told to put your arms up, and you can't do it, so you're sent to run some more. Now, we know this intuitively, but why do we continue to fight it? Well, what's going on? When a patient who's having trouble breathing tripods in any fashion, what it's actually doing is engaging all of the accessory muscles you have to breathing. You're bringing in your neck, shoulder, side, back muscles. What that does is it actually allows you to pull your chest bigger than just normal standing. And then it allows you to crush your chest smaller than normal standing, both of which allow you to lower the pressure greater and increase the pressure greater than standing alone. In fact, what this does is eliminates your use of accessory muscles. You are actually less able to breathe with your arms up than even just standing. This is the worst possible position for someone having difficulty breathing or trying to breathe. So what does this all boil down to? Let your patients who are having trouble breathing get in a position that's good for them, as long as it's not dangerous. And if someone's tripoding, let them tripod, but recognize it's a breathing problem. Manage your asthma, manage your hyperventilation, and assist your patients when they're working hard to breathe.